If it is a benign, it will show the benign characteristics. If it is a malignant, you suspect that it might have a metastasis. What are the things you're going to look for metastasis in the neck?
The other.
Lymph nodes. Lymph nodes and other thyroid gland. You need to see, because you need to know that there are hundreds of lymph nodes in the neck. And if you see the other lymph nodes are enlarged, then you have to be very careful. That if there is a lymph adenopathy, they will take the biopsy materials from the lymph node, or they might take a lymph node out and they will send it to the lab to see what is happening. Is it inflammatory or metastatic? Don't forget that any neck swelling, you have to take history of radiation. History of radiation, history of occupation. What do you do? What is your occupation? What is your job pattern? So these are very important. You need to know that. So we understood that because of the location, because of the shape, size, it is very difficult to differentiate it from the thyroid gland mass. So this is important. So now we're going to discuss about the pathology. Okay, we're going to discuss about the pathology. Pathology of the thyroid, parathyroid gland. Number one, adenoma. Adenoma, yes. And carcinoma. So adenoma comes from the normal functional tissue of the parathyroid, and it is a glandular endocrine gland, and it has a glandular cells. So the pathology will come from these glandular cells. That's why its name is adenoma. And adenoma is a benign. It's a benign tumor. And responsible for 80% of primary hyperparathyroidism. %80 of primary hyperparathyroidism. So why it is called primary? Because there is some secondary cause. It is associated with exposure to ionizing radiation. Ionizing radiation due to other causes. Okay, it is a benign tumor responsible for 80% of primary hyperparathyroidism. It is associated with exposure of the ionizing radiation due to other causes. That's why we need to take the history from the patient. And sonographically, sono appearance. What are you going to see? Most typical is a well circumscribed nodule at the posteromedial border of the thyroid gland. Most typical is a well circumscribed. Well circumscribed means is clearly seen. Nodule at the posteromedial border of the thyroid. That I drew it before and I explained, I showed you and I discussed about it. So it is found along the posteromedial border of the thyroid gland, commonly homogeneous, and hypoechoic. It is more hypoechoic than the thyroid gland, so that in that way we can differentiate it, that it is more because of the position and more hypoechoic and homogeneous, so it could be parathyroid gland. So it is homogeneous and hypoechoic. Hypoechoic means is more darker than the thyroid gland. Then in benign you might see the hypervascular. Because of the feeding artery. If the adenoma is in active phase, then you will see there's a feeding artery supplying the parathyroid gland. Okay, so now this is adenoma, now cancer. Okay, carcinoma. We will discuss about the carcinoma. You did it? Yeah. Carcinoma. Carcinoma should be the working diagnosis of patients with primary hyperparathyroidism. What does that mean? Should be the working diagnosis of patients with primary hyperparathyroidism. That means if anybody get the primary hyperparathyroidism by doing the blood test, and its level is high, I told you the 10 times higher, then automatically it should be the working diagnosis of carcinoma. Working diagnosis of carcinoma means I will say, oh, it is most probably cancer. Why? But usually the parathyroid hormone is not increased in normal condition. And look, the rise of hormone level is too much. So that's why I will consider this is a malignancy, carcinoma, unless otherwise proved. And serum calcium level may be very high. May be very high. That's why you will see serum calcium level is always done in routine blood exam. Always done. Because calcium level is up and calcium level is down. It's not only evaluate the parathyroid gland. It also gives us informations of the vitamin D, calcium, calcitonin, and parathyroid hormone. It's all related. Okay, so this is one more thing. Thyroglossal duct cyst and lymph node pathology in the neck. It is important. Let's talk about it. I discussed about the anatomical situation, how the thyroglossal duct cyst is developed, and what is its name, and what could be the consequences or complications, and the treatment. Okay, no thyroglossal duct cyst. It is in the neck, it is in the midline structure. That's why it came into consideration of the cosmetic disorder. Okay, that's why people will go to the doctor to evaluate what is this and it's bothering me. So you can do the surgery, you can take it off that thyroglossal duct cyst and problem is solved. Okay, so now thyroglossal duct or tract extends from the base of the tongue to the thyroid isthmus. And we can see the thyroid isthmus is connected at the midline with some echogenic structure, that is thyroglossal duct tract. And if you ask patient to swallow, you will see that the tongue is moving, so isthmus is moving, so whole thyroid gland is moving. Cyst and fistula can form when this structure fails to atrophy after embryonic migration of the thyroid gland. Can be present at birth. (25% cases). Most appear in early childhood. Remainder appear after age 30. Prone to infection. May rupture spontaneously. Treatment includes removal of the cyst and the ducts and the duct. Okay, these are the summary of that thyroglossal duct cyst. Now I will talk about the sono appearance. Sono appearance of the thyroglossal duct cyst. You might say cystic to complex appearance. Cystic to complex. When there is a cystic, that means it would be a completely cystic. It will have a smooth thin wall, anechoic inside is refracting shadow, and there will be enhancement. Okay, you can see the cyst where? In the midline. At the midline, it is so superficial, it will be appreciated if you use the stand-off pad. Stand-off pad, because it is so superficial. You might see the complete cyst, or you might see a complex appearance because of the infection. Okay, this is complex because of the infection. Usually what happens, if it is a midline structure and is a bump, people usually squeeze it, palpate it, and bleeding takes place inside and infection takes place. So this is sono appearance cystic to complex. Usually midline between the isthmus and the hyoid bone. Where is the hyoid bone? Hyoid bone is above the thyroid cartilage. See Adam's apple here? That above it, there is a hyoid bone. Thin bone. Okay, so in the midline structures, I drew the anatomic view before. So this is the trachea, and you will see this is thyroglossal duct. Usually get fibrosed. Here you will see the midline, small swelling, just like a size of a green pea. This is thyroglossal duct cyst. Thyroglossal duct cyst, and this is the thyroglossal duct or tract, and this is thyroid. This is isthmus, and this is the lobe, right lobe, and this is left lobe, and this is right lobe. Okay, then you will see the tracheal ring. Okay, so this is our sono appearance. It could be between the, so look, this is hyoid bone. This is hyoid bone, and this is thyroid cartilage. This is hyoid bone. Okay. So now I will discuss about the lymph node in the neck. Can I erase?
Yep.
And this all includes in the heading, broad heading, that neck pathology. Neck pathology. Neck lymph node pathology. So you can say, let me give the big heading. A is the benign pathology. Benign pathology and metastatic pathology. Benign pathology is due to several types of infection. Several infections, and or you can say several conditions. So, number one, viral and bacterial infection may enlarge the lymph nodes. Example, viral, the we call it mononucleosis is a virus. Sometimes viral infection, upper respiratory infection, there's the lymph node enlargement. Bacterial, like a tuberculosis. Tuberculosis causes lymph node enlargement. Yes. Sometimes malaria, filaria, kala-azar, those are the parasites. They can cause lymph node enlargement in the neck. So that is one. And number two, cervical lymphadenitis. Is the most common mass in children, often following upper respiratory infection, especially children. Ear infection, nose infection, throat infection, common cold, the lymph node enlargement. But the metastatic pathology of the lymph nodes cannot be differentiated from benign lymph adenopathy. So, cannot be differentiated from benign lymphadenopathy. So then what happened? If it is not differentiated, so then they will do the biopsy. Okay? That means needs biopsy. Now, sonographic appearance. Single well circumscribed circular or oval hypoechoic nodule. Single